Our second, but really first speaker for the day is Dr. Alex Pearson. He's an MD, PhD. Did his medical school training at University of Rochester in New York, and then decided to go to warmer weather and went to University of Michigan for residency and fellowship in hematology oncology. So actually, I'm just looking at this. Did you do your PhD at Michigan?
I did my PhD in Rochester.
Okay, I'm looking at your profile on University of Chicago. It says PhD, University of Michigan. So.
Oh, okay. Well, I guess I'll take that too. That's a great.
Yeah. I not to get off track, but I have heard of programs where as residents they have a PhD track. So that's why I was asking. But anyway, so he is now a head and neck cancer specialist here at the university, and his research I will let him tell you more about. But I'll turn it over to him. So thanks for joining us.
Thanks. So I am going to talk a bit about some of the basics for medical oncology for your to have some grounding for your summer experiences, and then we can, depending on how much time we have, we can talk as much or as little about machine learning as anyone has appetite for. So I just to get started, I do serve as an advisory on an advisory board for Prelude Therapeutics, although that won't impact anything I'm going to talk about today. So the topics that I'd like to cover are what are some of the things that make cancer different from the rest of our cells, and how do we use these concepts for treatment? What is the shared language to best define best clinical practice? And then what are some of the drugs that we can use to kill cancer cells? So those are the kind of topical or the language components that I'd like to cover. And then we can spend some time talking about why and how I chose to treat cancer. So who's seen this graphic? Has anyone seen this graphic? Oh, great. Okay. So I meant to include this. I will send I have the citation pulled down. I just didn't send it out prior. But this is it's a superb tome, as it were, defining what's called the hallmarks of cancer. And so this is a really, incredibly frequently cited from incredibly frequently cited work in Cell, and has effectively defines the things that are essential to a cancer cell to be a cancer cell, and then how we might target that cancer cell. So it's really what I love about it is that it's one of the defining concepts for how we think intellectually about cancer. And since I think that it's intellectually cancer, the study of cancer is one of the most interesting aspects of medicine, that I really love this as a defining characteristic. So cancer cells avoid growth suppression. In other words, they have a cell cycle, which is generally on, which is why cancer cells are growing when the rest of our body is not growing. They avoid immune destruction. So you may have heard the statistic that on average, we all get cancer if we live long enough. And that one of the key components to that is that our immune system is able to successfully eradicate the majority of those instances of cancer, and that the unfortunate lack thereof is what might translate into to an active and detectable cancer. Cancer cells have replicative immortality, which means that they have no limit on the number of times they can reproduce as a cell, as opposed to a terminally differentiated cell that has intact telomeric controls on it. They have inflammation, or within the tumor there is a significantly more inflammation, which is one of the pro-growth signals which cancer can use to thrive on. They can invade and move. Cancer cells can. And so one of the things that oftentimes differentiates a benign tumor from a cancer is its ability to spread to other organs. It can regenerate its own blood vessel source. So that's angiogenesis, and in order for a cancer cell to, it doesn't always do this with high degree of accuracy, but a cancer cell has the ability to feed itself off of our own bloodstream. Cancer cells are much more genomically unstable than a standard cell, which is how they beget additional alterations, is that they have an unstable genome, and that they can acquire over the course of their life more and more alterations, which can make them more aggressive and less susceptible or less likely to respond to therapy. They resist cell death. So in addition to being able to grow without control and divide without regulation, they can also they also don't undergo a standard cell death apoptosis process. They can disrupt the body's normal energetics pattern, which means that even in the setting, you will have a patient whose cancer is growing, even as they become more cachectic, because the cancer is able to be so greedy as to suck up all that all that nutrients, and they can sustain proliferative signaling. So each of these components is something that differentiates a cancer cell from a non-cancer cell. And the eternal optimist in me as an oncologist also says that each of these differentiators is also an opportunity to target and kill cancer cells. And so as our understanding of cancer has developed, and this will be maybe implicit if not explicit through the rest of my slides, our approaches become more specific. And I'm talking about primarily about medical oncology approaches, but our approaches become more specific in terms of how we can target and kill cancer cells. And so each of these, I encourage you to look when I send out the PDF, but the hallmarks of cancer will give you a great overview of how we view targeted therapy in general. So in terms of the language, has another speaker gone over cancer staging?
Dr. Hoffman did it very, very briefly.
Okay.
This might be a good refresher.
All right, great. So cancer staging, when we talk about cancer, we generally talk about the stage of cancer, which just defines within a formalized rubric how aggressive do we have to be from cancer to cancer in order to get rid of it. So the staging is specific to something as maybe to an organ as specific to the region of the mouth where your cancer came in my realm, but in general the stage from cancer to cancer shares a number of specific characteristics. That is how large or invasive the primary tumor is. That's the T stage. The number and proximity of lymph nodes where the cancer has spread to regionally, which is the end stage, and the presence or absence and number of organs potentially that the cancer has spread to distantly, which is the M stage. So together, you will have a T number, an N number, and an M number, all of which will add up to a stage 1, 2, 3, 4 cancer, and what we call the AJCC rating system. All this tells us is this formalizes a structure that we can test different ways of treatment within, right? So that we want to have the ability to call an orange, and then to try 2 different treatments on that orange and see which one is most effective at getting it peeled. So you may see some modifiers if you're working in a clinical setting this summer or on a clinical project, that in addition to this TNM and stage 1 through 4, which is on a cancer by cancer basis determined in a spreadsheet of the combinations of T, N, and M stage, which make cancer stage 1 in lung or a stage 4 in head and neck. You'll also see these precursor precursor files, which includes C, meaning a clinically derived. So what that would be if you come to my clinic and I have a CT scan, I'm sorry, if I do my physical exam and see a cancer of a certain size in your mouth and lymph nodes of a certain size on one side of your neck, I might assign a clinical T2 N2 cancer, a stage 4A cancer to your tongue cancer. That's distinct from the final stage after definitive therapy with a surgical approach, where we would be able, where our pathologic colleagues can assign cell-specific modifiers from the pathology directly from the microscopic evaluation of that sample. So that would be a P stage. So that's typically after the treatment, although it depends on cancer to cancer. The Y, if it's a Y or a YP, that would be a stage after a neoadjuvant therapy, and an R would be recurrent. So that we sometimes see precursors up to three letters long. You might see something in a chart which is like YPR T2N1 M0 or even MX, head and neck cancer, which would define a cancer after it has received some treatment in the recurrent setting and then been resected from a pathologic perspective, but that the metastatic compartment has not been evaluated. The other component that we use to determine candidacy for treatment potentially is how healthy a person is. And so we call that performance status. And if you're ever asked a question on any board exam and performance status is a predictor of outcome, it's always performance status. So the ECOG performance status is dependent on how much self-care a patient is capable of, and it is extremely predictive of their candidacy to receive chemotherapy. So it's a very simple, there's a number of different performance status. But the point is that that even if you have a cancer that is curable on paper, you may not have a cancer that is curable within a person if their performance status is so poor due to cancer or non-cancer related factors. Okay, so with those two constraints in mind, meaning the definition or the construct of the cancer and the construct of the host, we can start talking about what are the paints that medical oncologists paint with. Do you like maybe it's a crude analogy because we're mostly technicians, not artists, but nonetheless, cancer therapies exist in a number of different types, and we've alluded to some of those on the hallmarks slide. Chemotherapy typically refers to was for a long time the cornerstone of medical oncology, and it referred to that class of very toxic drugs that was responsible for killing cancer cells faster than it killed the rest of our cells. But formally, these are cells that were most toxic to, these were drugs most toxic to dividing cells. And you can imagine that even as adults, there's lots of dividing cells in our body, and therefore a chemotherapy drug principally can have toxicity effects to any dividing cell, just like it should have toxicity effects to any cancer cell. We've added to that just within the last 5 years this incredibly important class of drugs called immunotherapy, which modulate our own immune systems to recover the ability to identify and kill cancer cells. And we'll talk a little bit about some of the frequent ones. But they sometimes alert the immune system to cancer cells presence, and other times increase or decrease the regulation on the immune system so that the barometer or the sensitivity of the immune system is heightened. Targeted therapy is a term which used to mean more than it does now, in that we are referring to to classes of drugs which interfere with a specific molecular pathway. So in other words, it's not killing a cell just because it's dividing. Rather, it's interrupting a signaling pathway, a cancer biology canonical signaling pathway that you hope a person's specific cancer is more dependent on than the rest of the cells in their body. And so oftentimes targeted therapy is talked about in combination with precision oncology. In other words, in an ideal world, if we had a drug that interrupted a dysregulated pathway, we would also want some measure of why that pathway was dysregulated. And that might be next generation sequencing. That might be special histopathological staining. That might be some other mechanism by which we could quantify that a cell is dependent on HER2 and therefore would benefit from being treated with Herceptin, the drug that targets HER2. And finally, endocrine therapy are classes of medicines that block hormones wherein cancer cells have dependency on them. So it's a subclass of targeted therapy, but a really, really frequent one. So between breast cancer and prostate cancer, just for starters, those are incredibly common cancers for men and women, for women and men respectively. And so we are oftentimes able to specify the off-target effects into those specific hormonal or endocrine systems, and leverage the fact that many times cancers that arise from a hormone-bearing organ like a breast tissue or prostate tissue retain those same hormonal signaling structures and therefore can be slowed with use of exogenous hormone blockers. As you are learning about your summer projects and figuring out, how a specific cancer treatment or biological concept might fit into the overall rubric, I think one great resource, if you haven't looked at it already, is the NCCN guidelines. And this is effectively the body that says what the portfolio of options may be for treating a given cancer within a given T, N, and M stage. And so this is a free resource, but it's one that is incredibly valuable for understanding the landscape that you're operating in. And oftentimes summer projects might be so specific that it's locally advanced bladder cancer, and you might be only looking at 3 or 4 pages of a 200-page NCCN document, but it would define all of the potential treatments that would be available to a patient analogous to one that your research project was focused on. So here's just a call out, a half of one of the pages for metastatic colon cancer. We'll use a lot of chemotherapies that we'll continue to talk about. We also use chemotherapies in a lot of different ways. And so this is a list of some of the terminology that you'll also see as you're reading about chemotherapy. So neoadjuvant means chemotherapy prior to surgery, typically to reduce the size of the tumor and hopefully make the surgery technically better or the outcomes improved. So the part of the neoadjuvant part means that it is part of a package that formally includes a true definitive or essential component of additional care that is not the chemotherapy part. So it is necessarily prior to the main event. Adjuvant, on the other hand, is chemotherapy that is added following the main event to further reduce the risk of recurrence in an individual. So that again is not the main event kind of chemo, but rather one that can be bolted on to an existing plan of care. Induction can be very, depending on the group, this might or might not be analogous to neoadjuvant chemotherapy. It is chemotherapy Again, with designed to give a response. And in solid tumors, this gets really murky whether or not there is a true distinction between neoadjuvant and induction. Typically, neoadjuvant is pre-surgery, and induction is a term that was taken initially from liquid malignancies like leukemia, and has now been used in our head and neck group. We use it a lot. Consolidation is chemotherapy that has been that is used to sustain an emission and remission once that has been induced. So typically that's lower intensity chemotherapy given over a longer period of time. Maintenance, again, is ongoing chemotherapy that is serving to change the balance of cancer in its environment. So this would be oftentimes chemotherapy used when, for example, a tumor has been put into a quiescent state and you're hoping to keep it there for some period of time. But typically lower intensity chemotherapy that can be given for many months. And then palliative chemotherapy is chemotherapy used without curative intent. So those would be in cases where we don't have the ability or don't have a host capable of tolerating intensity required to cure cancer or feasible to cure cancer. Palliative is to give to reduce symptoms, prolong quality and quantity of life. And so when I talk with my patients about this, I say, I want to give you the most number of good days, and I use palliative chemotherapy to do that. Chemotherapy is given, the nomenclature is cycles. Each cycle of chemotherapy includes drug administration, some days where you get drugs, some cases where you don't get drugs, and some combination of drugs given in a repetitive phrase or period. So we give a lot of cycles of 2 weeks, 3 weeks, 4 weeks in length, and these cycles can be really complicated. It can be multiple phrases. Some of the pediatric leukemia or lymphoma regimens are really complicated because they're incredibly high intensity and alter a lot of different drugs over a period of time. So the course is the number of cycles. So if I am planning a period of three week long induction chemotherapy cycles for a head and neck cancer trial that I'm running, it would be one chemo course of 3 cycles, each 3 weeks long. And we talk about them in the cycle day format, where there's the number of cycles you're in and the number of days, and that helps us keep track of the expected toxicities of the chemotherapy that might happen more likely on day 2 than on day 20 of a 21-day cycle, for example. So in our minds as practicing oncologists, when we hear the cycle and day, we're thinking, okay, is this person, should this person have their marrow should look good, their blood counts should look good, or should they be, retching at home because they're so nauseated after their chemotherapy infusion? So it's all context in terms of how the toxicities apply to the patient. We're going to talk a little bit about some of the specific types of chemotherapy, just so you've seen these words, but we spoke before generally about chemotherapy, that they are they're cells that are dependent on killing cancer. They are therapies dependent on killing cells. And so many of these old school, these previous generation of traditional chemotherapies are active at different points in the cell cycle. And so this is important as the drugs were being developed, because it would alter the way you would deploy them. So for example, there are some cell cycle and some non-cell cycle dependent types of chemotherapy. And you might deploy them differently if you had, for example, a very quickly growing tumor versus a very slow growing tumor, because you could make an estimation of how long a cancer cell was spending in a cell cycle, it's cycling in a given cell state or not cell cycling. And so I know you all have seen this, but for example, in the there are a certain class of drugs that are active in the S phase, and another class of drugs which are active in either G2 or M phase. And so the biology or the mechanism of action is all dependent on how the drugs themselves interfere with the reproductive machinery. But there are choices to be had as you're organizing cancer therapy. So here are some of those classes. There's 2 sheets of these, but each of these, you can see that the mechanism of action here in the center column is informs how we deploy these drugs. So for example, the antimetabolites may impair or alter the way the DNA or RNA synthesis happens. And so, for example, 5-fluorouracil is generally cell cycle specific. And so it is oftentimes given via pump over multiple days through a port. And so that means that it has to be on board as a cell is cycling in order for it to be effective. And so we try and stretch out the total amount of time that cancer is present in a person's body in order to maximize the effect, the potential for effect on a cell. That's always balancing its effect on bone marrow or other organs, for example. But that's how the pharmacology informs the strategy.
Alex, sorry to interrupt. There's a question from the
great.
From the group. Since kids have more dividing cells than adults, why can they tolerate more intense treatments?
That's a good question. I'm not a pediatric oncologist. No, I'm I think generally kids tolerate more intense treatment because their inherent cells are more robust against the toxins we throw at them. So their marrow is more able to detoxify. They have intact telomeric and detoxifying cell processes that equip them in a ways that adults just can't tolerate. But if you've worked on a pediatric oncology unit, you will also know that no child escapes high intensity curative therapy without permanent side effects. So it's not to say that they are escaping the toxicity, but rather that we can push them farther without the therapy being fatal. So it's a relatively, I think, morbid concept, and it was an aspect of pediatric oncology that I really didn't like, even though I did like the preponderance of data collection. So it is mostly a lot of what I think until the more recent targeted therapy era, the thinking by and large was that we need to push toxicity to the absolute limit in order to get rid of cancer cells, and that the mechanism to that was just pushed the furthest in kids, which were able to tolerate the most. Other questions, since if we're paused? All right, so just some of the other mechanisms with which chemotherapies are affecting cancer cells. So alkylating agents interact directly with the DNA or RNA. Cisplatin, which is a drug we use a ton in head and neck cancer, it forms adducts between the two strands of DNA. And so when the repair mechanisms are evaluating that double strand, it finds that alteration and therefore flags the cell as needing apoptosis and clearing. Again, anti-tumor metabolites are unwind the helicases and therefore are specific during S phase, but as their specific mechanism of action. Vinca alkaloids disrupt the mitotic spindle formation and are M phase specific. Taxanes stabilizes microtubules in order and otherwise pausing the M phase or pausing the cell in M phase. And then topoisomerase inhibitors induces double strand breaks as well as inhibiting one of two specific enzymes. So I think this is a is this a schema that you may have seen? This is from some of the board review tests, but this is a visual a reminder of common chemotoxicities. So the C's for cisplatin and carboplatin have toxicity of ototoxicity, that means ear toxicity, and kidney toxicity. So you can remember those kind of semicircles. Vincristine and vinblastine have a lot of peripheral neuropathy, and they're here are the V's for hands and feet. Taxane is another drug that has a lot of peripheral neuropathy, not included on the schema, but really common given that it's used a lot in breast cancer. Bleomycin classically has pulmonary toxicity, and so particularly for young people with bleomycin containing regimens, you have to watch for lung function change or physical exam findings of that toxicity. Doxorubicin and trastuzumab here as the D and the T both have cardiotoxicity, which means that since they're both frequently used in breast cancer, requires ongoing evaluation. The CY for cyclophosphamide is concerning for hemorrhagic cystitis. And then the 5 and 6 MP, or 5-FU and 6-MP are both 5-fluorouracil would be the 5-FU, and those are both responsible for myelosuppression. So they're here exemplified in the long bones of the legs. So I talked a bit about just specifically to chemotherapy-induced myelosuppression. We talked a bit about how that cycle and day nomenclature was so important, and that's because some of the frequent causes for chemotherapy-induced hospitalizations are related to are temporally related to when the chemotherapy was administered. So that we think about this periodic toxicity and recovery, which is dependent on the dose and the organization of the chemotherapy being administered. But we go through these cycles with patients having repetitive plans of chemotherapy with this sequential nadir or decrease in cell counts and then recovery. So there are some times where we actually have to patients bone marrow from previous insult or from the intensity of chemotherapy or don't perform well enough and require external stimulation. And we can give that through recombinant growth factors to either prevent or avoid dangerous neutropenia, meaning low white blood cell count, which can predispose individuals for sepsis, even in the absence of being able to mount a febrile response. So just a couple of comments on targeted therapies, or switching gears to targeted therapies. So we talked about that these were concepts that interfered with specific molecular targets, and how they are the primary discriminator for targeted therapies compared to chemotherapy. So they act on a specific subset of enriched cancer cells. So within targeted therapies, we're going to talk about some of the discriminators. So small molecule drugs are targeted therapies. It's what the name describes. Instead of it being a large engineered protein-based molecule, it is a much smaller freely diffusing organic or inorganic compound, which has been designed or tested to interfere with a molecular pathway or pipeline without being a engineered mimic of the protein at play itself. That's opposed to monoclonal antibodies, which are the full engineered protein structure with which can be synthesized, or I should say engineered in a lab to potentially do a very similar task as the native protein, but potentially with more stability or improved properties for activity. So typically, if you're talking about small molecule drugs, it will end with nib, meaning the suffix will Pearsonanib as the name, or mib for proteasome or protease inhibitors, and that's as opposed to a mab like infliximab as a drug that would be an engineered larger protein monoclonal antibody. So there's a lot of interest in small molecule drugs because they're cheaper, they have preferred drug qualities, but it can be a lot harder to identify them because it is not as simple as cloning the protein or endogenous target of interest. So some that you've probably seen, the monoclonal antibodies, rituximab, bevacizumab, which are anti-CD20 and anti-VEGF antibodies respectively, and then some of the small molecule inhibitors, all with common usages, but targeting specifically one or more receptors, but with a different structure and organization type. So moving on, again, we want to talk a bit about immunotherapy. So we mentioned that immune checkpoint, one of the ways that cancer evades killing is by disproportionately signaling a negative inhibitory signal to our immune system. So when the T cell comes to check whether or not this is something it should kill or not, a cancer cell has a number of these negative inhibitors or negative regulators, which limits that T cell from being activated in order to initiate the cell killing. So we call that regulatory mechanism the immune checkpoint, and immune checkpoint inhibitors bypass that to allow the T cells to kill cancers. So we've got a couple of common, really frequently used pathways or immune checkpoint pathways that are druggable by cancer. This is something that may show up on any stage of your steps or board exam, because this is, I would say this is well within fair game. And some of this work won the Nobel Prize in Medicine, 2-3 years ago now. So there are two of the primary druggable immune checkpoints, which have FDA-approved drug indications, include CTLA-4, which is a negative regulatory, an inhibitory signaling pathway to T cells from antigen-presenting cells, and the drug, the anti-CTLA-4 drug ipilimumab, targets that T cell side receptor. So thereby removing the ability to be negatively regulated and increasing its affinity for cell killing. That's the other primary immune checkpoint pathway is the PD-1, PD-L1 pathway. And so T cells express programmed death receptor 1 and its ligand, programmed death ligand 1, is expressed on tumor cells. So any cell that's expressing PD-L1 is wanting things to not find and kill it. So there are drugs that target both the tumor side and the T cell side of this negative regulatory pair, PD1, PD-L1. And this has been, this is FDA approved. The PD-1, PD-L1 pathway is FDA approved now in dozens of different indications. And so there are many different approved molecules for the both PD-1 and PD-L1 pathway. So PD-1 pathway, again, that's the one it's on the T cell side, and generally thought of as being more active. So the PD-L1 studies have been more disappointing compared to the PD-1 studies, though both are active. Both can be active in many given tumors.
What do you mean by active? Like that it just does that mean it has like higher affinity, or?
I think that what I mean is, if you have a parallel trials, sometimes very similar trials with a PD-1 or a PD-L1 drug as the active or candidate agent, have more disappointing results on the PD-L1 side. And I think that, everything else between, the drug and the trial design might be at play for why there's this kind of consistently discrepant results. So we don't actually know why, for all the reasons why, that drugging the T cells is a better strategy than drugging the tumor cells, but it does seem relatively consistent. There's been kind of a series of disappointing PD-L1 trials come out one after another, which gives us this kind of gut sense that there's a difference. But none of the pharma company strategy. Well, pharma companies never have this strategy, which is let's compare two drugs side by side and see which one's better, right? That hardly ever happens unless they're comparing it to a generic. Merck has made so much money on pembrolizumab that their concept, I think in general, the concept has been to race to as many different affirmative indications for treatment as possible, as quickly as possible, and not to pay attention to the details about whether or not is a given strategy the best we can do. That will come, but we're still kind of in the we're in the phase in drug discovery, which is really more like, what is the portfolio of things that seem to work pretty well, and then we'll optimize them later.
Thank you.
So what comes with these?
Sorry, I was going to say there was a question about autoimmune risk. So perfect.
Oh, I can't see the chat. I can't actually see my screen and your faces and the chat all at the same time. So feel free to interrupt me if something goes in the chat. So just the same way, we didn't spend a lot of time talking about it, but as you can imagine, and maybe this is permeated into your, the kind of cultural realm, but chemotherapy drugs, traditional chemotherapy drugs, have side effects that are clustered in cells that are dividing. So your hair falls out. You have diarrhea because your GI tract is always dividing. You have myelosuppression because your bone marrow cells are always dividing. Your skin changes quite a bit because your skin cells are always dividing. And analogously, immunotherapy drugs have immune-related adverse events. And the immune-related adverse events are a little funnier because they are harder to predict to whom they will happen. And they are more variable in terms of their timing. So the average patient who's on immunotherapy has a little bit of fatigue, but the extreme patient who's on immunotherapy can have dramatic, life-threatening, or even fatal toxicities from their treatment. So I usually say that the most common Most common toxicity is fatigue. The most common quality of life altering toxicity is diarrhea, because a little bit of diarrhea, low-grade diarrhea, can ruin your life. That's what one of my mentors always told me. And then pulmonary toxicities can be, are the most common dangerous toxicity, but rash and endocrine changes are also really common. So we see them, and it's hard to know to whom they will happen. Did I answer the question? I don't actually see the chat, so.
Yes, yes,
Oh.
thank you.
Okay, actually I pulled it up. I just can't pull it up on the same screen. Okay, great. So compared to chemotherapy, the timeline of immunotoxicity is much longer. It's not cleared as readily, immunotherapies that is. And they, our current thinking is that immunotherapy is active in the system at their current dosing schemas for months, or some people even think that there's a permanent kind of barometer reconstitution of the immune system once it's been retrained with immunotherapies on board. Okay, so that concludes the kind of chemotherapy descriptor portion of my talk. Just a brief run through of the drugs we use in medical oncology. Any questions? I have some points that I want to make about why I chose medical oncology. But I wanted to see if there's any questions or ambiguities before I pivot a little bit.
So in general, for the immunotherapies, are the side effects less than with chemo, just in general?
For the average person, yes. The much better tolerated. And in those, there are some studies that have been done in cancers that are relatively likely to be immunotherapy responsive. The patients who have an immune profile that is suggestive of an increased likelihood of immunotherapy response on the tumor side, their quality of life is much higher, in addition to their quality of their quantity of life being longer. So in other words, the immunotherapy implicitly, what we're all thinking that I didn't actually say out loud is there is this small percent chance of a long-term stabilization of advanced cancer with immunotherapy, that it happens at a higher frequency than any other class of drug generally has across most cancers. So in head and neck cancer, for example, we would never be able to, to accomplish a year of disease progression-free survival in previous times, except in really rare cases. And now there are some, it's not a ton, but 20, 25% maybe of patients whose cancers kind of reach a homeostasis a new homeostasis with their immune system, even after growing. And they may just kind of truck along where we can see where their cancer is on a CT scan, but it stops growing. And that has really been the tremendous promise and what a lot of what the excitement about immunotherapy is. It's not just another drug with a kind of a miserable 15% response rate that you can reach to in the 38th line, but rather it's a totally different set of well-tolerated therapeutic concepts, which allows patients in some cases, and we hope in the future even more, to live with their cancer instead of fighting against their cancer. So yes, the key points there are, for the average patient, I've got patients that are like 2 years out. They work in the Northwest Indiana steel plants. They go to work every day and they have metastatic cancer. And it's like, this is not something that happened before. They just got back to their life. This is not something that we had a concept for 10 years ago. So medical oncologist. That means you're the chemotherapy and immunotherapy drug purveyor. And generally, it also means that you are the chaperone of advanced treatment. So you are the person that's responsible for symptom management. You're also probably the most frequent cancer-related subspecialist responsible for delivering bad news and for talking about goals with your patients. So what this translates to is it's wholly unique, in my opinion, therapeutic alliance between patient and physician, particularly among the internal medicine subspecialties. Cancer has a kind of a privileged place as a foe in society, and that is a really unique aspect for being the person who treats that entity. So you have to cajole a patient into taking their chemo less than you have to cajole a patient into taking their diabetes medicine. And that is unique, and that was something that I found very appealing. You are all really working with your patients for a shared goal, which is fighting their cancer, which is it's just less to convince a patient of that this is something important and that you need to treat them. I also think that for everyone on the call's sake, if you're here, you're invested in fascinating concepts. And just as they call cancer the emperor of all maladies, it is also the paramount intellectual opponent within the medicine subspecialties. So I'm a mathematician. I mean, I did my PhD in statistics, and so the thing that's absolutely the most fascinating is that no matter where you want to look, there's a fascinating challenge in cancer. So I think about this at scale, right? Every scale of cancer has an absolutely fascinating quantitative problem that you could identify. The molecules are altered, right? The actual DNA strands are messed up in systematic ways and in patterns that are, screaming to be identified. Communities of cells are messed up. They're growing abnormally. They're not subject to standard constraints. Those communities are interacting with their environments, right? They are these groups of abnormally of cells that may have hijacked the stromal system are also trying to get away from the immune system, which is trying to kill them. We've got all the best drug treatments, right? No one produces as many clinical trials as medical oncology. And so we have tons of new drugs coming out, new challenging ways to think about treating our selected disease entity. And then we have problems at the community level. We have, there's dramatic amounts of inequality in the way we deliver what could be fantastic care, but is oftentimes not. And there's innumerable cancers that could be prevented, excuse me, and are not being prevented. So whether you want to look at, the chemical base pair or the community of humans, there's a terrific question to answer anywhere in between there.
Alex, there's a good question. So Matthew asked, are immune therapies becoming more of the neoadjuvant or first-line therapies for indicated cancers, and also about tumor mutational burden? Are there some strategies to coax tumor cells to present more antigen to enhance immune therapy?
Yes, so I think there's two questions that I'll refine. So first is there's, our group and others are doing, there's a lot of work about the timing relative to the host biology of immunotherapy. In other words, if we're going to mobilize an immune system, we want to make sure that immune system is in good shape before we mobilize it. So, Dan, you and I share radiation patients, and there's some emerging evidence that potentially immunotherapy prior to radiation is better than immunotherapy after radiation. And there may also be an interaction during radiation. So I think that as this whole new class of drugs has come up, it's come up through the metastatic setting to determine its safety. And now we're exploring more and more its role in the neoadjuvant setting, and how can we use it before surgery, for example. Something that we have multiple active trials in the head and neck cancer group here exploring. And then your question, the second question is about tumor mutational burden. And we didn't talk at all about biomarkers. That didn't have quite enough time to cover everything that might be helpful. But tumor mutational burden is a biomarker. The amount of mutations within cancer are likely one component which enriches the cancer's the immune system's ability to kill those cancers, but it's still it's not a great biomarker. And so that there is, this is an area of extreme interest to lots and lots of stakeholders. Tumor mutational burden, PD-L1 staining status, or combined PD-1, PD-L1 staining, the specific mutational status, in addition, are all things that will be combined. But I think that while it is present, none of these are ideal and are not perfect predictors of response to immunotherapy yet.